Okay, well, welcome everybody. Welcome to our webinar, Transforming Primary Care for Older Canadians Living with Frailty. My name is Amanda Lorberg. I am the Manager of Research and Knowledge Translation at CFN. And before we get started, I would like to do, I'd like to acknowledge that the Canadian Frailty Network and Queen's University, our host institution, are situated on the traditional Anishinaabe and Haudenosaunee territory. We're grateful to be able to live, learn, and play on these lands. Now, I'd like to introduce our panelists for today. We are joined by Paul Stolee, Jacobi, Elliott, Anik, Giguere, Susie, Gregg, and Sara Mallinson. For the webinar, we do have time for questions at the end, so please use the chat function to submit your questions, and we'll get to them at the end and try to get through all of them depending on how much time we have remaining. This webinar is being recorded, and so we will have it posted online within a day or two if there's anyone who missed out or is unable to join us for the entire time. And we will have some future webinars, but they are currently scheduling in process, so none to announce at this time. So this presentation, this project is also associated with a lot of implementation resources. So they've created some knowledge mobilization tools. All are posted on our website. And we have a link on this webinar, but I'm sure that the project team can also inform you about where they can be found. Okay, so we have Dr. Paul Stolee, who's professor of the School of Public Health Sciences at the University of Waterloo. Also at the University of Waterloo, we have Jacobi Elliott, who is an adjunct assistant professor. We have professor in the Department of Family Medicine and Emergency Medicine at Laval University, Dr. Anik Giguere. Susie Gregg, who's with the Waterloo Wellington Geriatric Clinical Resource Consultant for primary care with the Canadian Mental Health Association, and she's also at the University of Waterloo. And finally, Dr. Sara Mallinson, who's a senior research and evaluation consultant with Alberta Health Services, and an adjunct assistant professor at the University of Calgary. So welcome team, project team. We're looking forward to hearing all about your success. So I'm going to go ahead and share the screen, and our presenters will be able to take it away. So Jacobi, are you able to share your screen? There we go.
Okay, I guess we're ready to start.
Go for it.
Well, my name is Paul Stolee. Welcome and thanks for joining us, everyone. On behalf of our larger research team, we're going to be presenting on implementation lessons learned during our project on early identification and management of frailty in primary care in 3 Canadian provinces, Alberta, Ontario, and Quebec. We are grateful for funding support for this project from the Canadian Frailty Network, for the support of many collaborating organizations and partners, and for the participation of the patients, healthcare providers, and administrators at our primary care sites. Next slide. The outline for the presentation is as you see here: project background, methods, the implementation process and lessons learned, and next steps. Next slide. So I'll start with a bit of the background on this project. Next slide. This project arose in part from past research, workshops, and events that have, all told, involved consultations with over 1,000 older adults and healthcare providers from across the healthcare system. Some of the things we heard were that primary care was seen as an appropriate hub for care coordination for older adults, and that there was value in strong links between primary care, home care, and other sectors. For many patients, primary care is where they enter the healthcare system and is seen as having a role in helping patients navigate the system and coordinate their care. The primary care setting also presents an opportunity for broad impact, reaching the greatest proportion of patients at the earliest point in their care and facilitating referrals based on patient need and preference. If we care for people in primary care at the right time, we can have a huge impact on the patient and on the rest of the system. Next slide. We know that older adults are high users of healthcare services. As seen here, the 16% of Canadians over the age of 65 make use of nearly half of healthcare spending. But we also know that the health system has many challenges. Visits with primary care practitioners may be too short to allow for in-depth assessment and care planning. Care planning and coordination may be inconsistent, and patients and their family members may not gain the information they need to manage their own care. This can result in poorer health outcomes and greater use of expensive emergency department and hospital resources. Next slide. And the health and health system challenges of older persons are likely to increase with increasing numbers of older Canadians living with frailty. CFN estimates this to be 2.5 million Canadians by 2030. Next slide. Based on our prior research, consultations, and literature reviews, we proposed to implement primary care interventions focused on consistent screening and assessment, patient caregiver engagement and shared decision-making, and care coordination and system navigation. And from this project, we hoped to learn valuable lessons related to implementation, adoption, and sustainability. There's a reference on this slide for a paper with a more detailed description of our project. Next slide. We worked with 9 team-based primary care teams in urban and rural sites in Alberta, Ontario, and Quebec. Next slide. Our proposed model involved a sequence of the 3 main elements I mentioned before: screening and assessment, for which we used the Inter-Eye risk screener and its associated assessment urgency algorithm; care planning through patient and caregiver engagement, which emphasized understanding patient and family preferences and developing relationships; and 5 shared decision-making tools; and also care coordination and system navigation. For this, we used an online platform called CareDove to link patients to services. Turning now to methods. Next slide. These were guided by an implementation framework we adapted from Dan Schroeder's Consolidated Framework for Implementation Research, or CFIR. Our adapted framework reflects elements of Bronfenbrenner's socio-ecological model and considers implementation in terms of multiple domains, including the outer environments of regional or provincial structures and community organizations, the primary care organization and the characteristics of the providers, and patient and family characteristics. In our model, we also place attention on the central support role provided by the research team. Next slide. Our work was done using a phased approach consistent with Sedani and Braden's recommendations for complex health interventions. This included a pre-implementation phase to understand current practice and refine the interventions, followed by an implementation phase with in-person and online training. Unfortunately, our research project was paused by the COVID-19 pandemic, which some of you may have heard of. We had planned for follow-up data collection at all of the sites. Unfortunately, this was only completed at one site before the pandemic halted further data collection. While this was disappointing, our team was able to place a greater focus on lessons learned, experiences of co-design, and the development of resources and implementation guides. Next slide. Before we get into our implementation findings, I'll just summarize that our data collection involved nearly 150 interviews and around 650 older adult surveys in the pre-implementation phase, and observations and meetings during the implementation process and training. Our co-design process involved work with primary care staff on how the intervention tools would be implemented at their specific sites. With that, I'll turn it over to Dr. Elliott to describe our implementation findings. Thanks.
Great, thanks, Paul. Okay, so as Paul mentioned, I'll move into some of our implementation findings. So during the baseline interviews, we learned a number of things that helped guide the implementation of the tools. For instance, we learned how important it was to learn from past implementation projects at the clinic sites. We needed to know, what made those past projects successful, what worked and what didn't work. We also discussed the process of training the clinicians, understanding how best to train the clinicians on these new tools. We know and we heard that time and competing priorities is a challenge when implementing any new work. We heard that we needed to make the implementation process really easy by embedding the tools into the current workflow. So these interviews that we completed really helped us understand the primary care environment at each site and allowed us to tailor the intervention based on what we learned. As we tailored the tools, we considered the logistical needs, the availability of technology at each site. So some of our sites didn't have great access to internet or didn't have electronic medical records, so really needing to tailor the tools based on that information. We tailored the tools based on the organizational structure, the provider roles and capacity to take on new tasks. For example, some of our sites had existing interdisciplinary team structures that already worked with some of the complex patients, so they could more easily take on some of the elements of our intervention. So again, really understanding what that primary care current environment looked like. This is one example of how we modified one of our tools in our intervention for multiple sites. So the screening tool was originally available in paper format, but of course we heard very strongly that clinicians would not complete the screening tool using paper. But the tool is also available as an app. So it's already available as an app on Android and Apple products. But we were also able to embed it into 3 different EMR systems across the different provinces. And in Ontario, it was also integrated into the Ocean platform as a self-report version for patients to complete on a tablet in the waiting room. So again, we took this one tool of our intervention and then tailored it 4 different ways for our different sites. Another example of how we tailored our tools is related to this decision box here. So decision boxes are about 23 pages long, and it's 23 pages of the best available evidence about a specific topic to assist with informed decision making. We heard from a couple of our sites that the longer versions were overwhelming for some of the older adults. So we created a 1-page version that we're calling a pre-consultation decision box. And patients and caregivers could review this version in advance of talking with the clinicians who would be referencing the longer versions. So again, we started our project out with this longer version, but as we learned from our sites and worked with our sites, we were able to tailor this tool into this pre-consultation decision box, which we also implemented along with the longer version. We tailored the training based on wants and needs expressed by the healthcare team and the organizational lead. We had daytime sessions, we had evening sessions, and we also had a mix of in-person and online sessions. The training did range from 3 to 4 hours in-person time, and then some additional online training. Following the training, the study team was available to each site as they rolled out the tools. So there was lots of emails back and forth as the team had questions as they were becoming familiar with using the tools in practice. Across the 3 provinces, we trained a total of 90 healthcare providers and clinic staff on all elements of the intervention. As we rolled out the tools in the 3 provinces, there were a number of common findings across at least 2 of the provinces. We used the implementation framework that Paul referenced earlier to organize these findings. So on the outer rings, the provincial and regional structure and community organizations, I'll highlight some of our findings. We really needed to have a good understanding of how our intervention aligned with existing provincial priorities, because this really enhanced buy-in at our study sites. It was also important for us to understand the primary care structures in each province, because they do differ, and tailor our approaches to the different primary care funding models. We also had some sites in rural locations, so we needed to consider the availability of internet connection for some of our tools, and also the availability of services where we might refer some of the older adults based on level of screening. The next level focuses specifically on primary care organizations and the provider, patient, and caregiver characteristics. So we found that many clinics were not currently using frailty measures or shared decision-making tools. And for some clinics, there was a lack of understanding of what these types of tools even were. So this was important knowledge for how we tailored our training for these sites. Prior to implementation, it was also really important for us to get buy-in from all levels of the clinic, so frontline providers, physicians, and clinic managers. As we planned for implementation, we needed to understand the clinic structure and payment models to understand which providers had capacity to take on more tasks or shift their current workload. We also learned how important it was that the tools were embedded into the electronic medical record for ease of use. And lastly, we have some consistent findings across the 3 provinces related to our intervention elements and central support. The findings are generally related to how we had to tailor the tools, such as translating the materials into other languages, as I mentioned already, integrating the tools into the EMR and the current workflow at each site, and understanding current referral patterns within the clinics. The project leads in each province also built very strong relationships with primary care staff during the implementation process. We learned that we needed strong and clear communication and implementation plans. We also had regular meetings between our central support team and the provincial leads to monitor the implementation and adjust our processes as needed. I'll now pass it over to Sara, who's going to talk about some of the specific findings in Alberta.
Thank you, Jacobi. So some of the overarching implementation lessons that Jacobi just outlined were obviously shared across the provinces, and I'm going to just add a little bit of extra detail on the Alberta experiences. There were subtle differences in staffing models, roles, and capacities that affected workflow in Alberta. We were working with 2 primary care networks, and primary care networks are a coalition of primary care clinics. So on one of our sites, well, at both sites actually, we began with a focus on family physicians, but quickly learned that the extended consultation time that would be needed to do the AUA screening, the decision boxes, and consider resources locally that were mapped on CareDub was not feasible during regular clinic appointment time, primarily because there was not a fee code that would be easily used for that. So we transitioned to looking at other staff in the clinic, and we identified family practice nurses as the group to work with. And in theory, they had more capacity to support program implementation. But as we moved deeper into engagement and tailoring, we learned that there were important differences in the way family practice nurse roles were organised at our 2 sites. So one site acted as the PCN acted as a coordinating hub for the family practice nurses who were deployed across multiple clinics, but came back into the PCN for meetings and education and learning sessions. At the second site, in essence, the family practice nurse positions were paid for by the PCN, but were attached to individual family physician clinics. There was much less opportunity in the second site for nurses to engage with the programme, and they felt that they didn't have capacity in their workflow to implement all the components. A really important but subtle difference in what the family practice nurse role comprised in those two different places. As Jacobi already mentioned, project champions make a world of difference to programme adoption. Alberta was not unique in understanding that we had to cultivate local project champions. And at our most successful site, we had excellent engagement right from the beginning and through to the end of the project. There was critical feedback, there was good meeting attendance, we had a regular meeting set up at the PCN headquarters. In the other site, we also had good engagement at the beginning with an engaged administrative officer, PCN leadership, and a nurse champion who was a real asset. Unfortunately, the local nurse champion went on maternity leave. The PCN leadership team departed en masse, and we could not find a way to sustain interest or motivation in the other staff, the remaining staff at that site. Not just because the project was kind of had lost its sponsor, but also there was organisational churn happening at the local sites that meant their workloads increased, and this project became less of a priority. Now, in terms of EMRs, Jacobi's mentioned how important it is to make things easy for people. In Alberta, we still have lots of different EMRs being used in different primary care clinics. We quickly learned that at one site, we could integrate AUA into the EMR. At the other site, we could not. And despite our best efforts and support from the administrator at that site, we could not find a way to embed the screening that the family practice nurses and other staff were willing to do. We'd built an Excel spreadsheet version of the AUA and added it as an attachment into the EMR, but people found it unwieldy and would not take that extra step. So ease of use is absolutely essential to getting people to embed a new step in their workflow. Beyond that, what we also learned was that where there's some flexibility in the EMR, it can actually be a really useful point of engagement with staff. So in our site number one, where AUA was embedded into the EMR, they actually had some local capacity to do some tailoring within the EMR. They didn't always have to go onwards and upwards to get technical support from TELUS, which was expensive and an extra step. They could own those minor changes. And in doing that, we found that that was a real mechanism for engagement, that they were critically reviewing the local rollout of the AUA. And that was a real asset in terms of critical engagement and ongoing development. And in that site, they have continued to use the AUA, which is quite exciting. The last 2 points I want to make here is about changing how people do things. We all know that behaviour change is really difficult. And I'm going to just draw on two small things, the cared of challenge and then the decision box challenge. The cared of platform was received with some enthusiasm at both our sites in Alberta. The staff liked the idea of services being mapped onto a simple searchable database And the potential to make referrals and direct booking from within the platform also generated interest. The challenge was that once we got down to the tailoring level, we discovered that staff in the PCN did not have unique, individual, secure emails, which would allow them to register on the CareDov platform and then go ahead with booking appointments and sharing patient information. So we had to remove that component. Once we removed that component, it was, we found that the incentive to use CareDov was somewhat reduced. So CareDov became essentially a directory. And although we'd populated it with a baseline level of information, the idea was that the more you used CareDov and the more you asked for different kinds of resources to be recorded there, the more it built depth and breadth in terms of mapping what the assets in the local community. And there was no incentive for people to do that. So it failed to take off. We were also aware at that time that other provincial resources were being developed under the 211 and My Health Alberta umbrellas. We also observed that technology moves quickly, and unless you can do something that people see as having a particular benefit to their work practices, you won't get traction. And finally, my last point builds on comments that Jacobi had already made about the shared decision making and the decision box challenge. In Alberta, we spend a good bit of time trying to understand what people thought the shared decision-making model meant, their preferences for doing shared decision-making, and the decision boxes that we were providing them with. And we were very sensitive to the fact that staff at both sites felt that they already did shared decision-making as part of their practice. And while they accepted the principle of needing best evidence and sharing that with patients and families, there was some subtle resistance to using these structured tools. And I don't think we ever got past that. One site didn't implement the tools at all, as far as we are aware, and that's linked all to the other things around churn. And at site number one, that team were engaged in helping us think about ways to adapt the decision boxes. So as Jacobi mentioned, we got short versions, long versions of the decision box for use at different stages in the patient engagement process, as well as printed versions and digital versions that made distribution very adaptable. Even so, at the end point when we began to wrap implementation, it was unclear to us that the decision boxes had been embedded into practice and would in any way be sustained. And those are my points from Alberta. Over to Quebec, I believe, next.
Hi, thank you, Sara. So do you want to switch the slides? Thank you. I think it was a great accomplishment of this project to be conducted in 2 languages. So we translated all the material, so in both English and French. So there were patient decision aids. The directory of services CareDov also was translated, the training. So it was a challenge, but at the same time, it proves that it's feasible and it's good to include Quebec in large pan-Canadian initiatives such as this one. During the project in Quebec, we were able to implement the intervention, the pathway. And so we had some findings related to what people, perceptions of people after the implementation. Some of the GPs felt that the current periodic medical assessment process that allows them to assess older adults was enough. So they sometimes felt that they were already covering the frailty assessment in this exam. I would mention, however, that the more seasoned providers seem to have made these comments. Some others commented that the screening might be beneficial to systematize assessment and for new doctors entering practice. A second element was that we found that the tools were not being used as intended. So some providers only used half of the tools. They seem to have presented only part of the decision aid contents or used them only with part of the patients. So it was not all, when we indicated to them, oh, this person is at risk, so you should present the tool, they only presented the tool to half of them. So in fact, this is probably reflective of the time required to go through shared decision making, the need for more resources, human resources to conduct these discussions that may take sometimes longer. For example, there's one tool about prevention of cognitive impairment. So typically, this tool would be discussed with people with mild cognitive impairment, and these people might take longer to understand the concepts presented in the tools. So, you know, this adds up. And I must say that the cognitive impairment prevention tool is the one that was most appreciated, because there seemed to be a lack of such tools in the tools they already had at the clinics. And it's also always a very important concern of older adults, the cognitive decline. So there was a high interest for the tool, but then at the same time, there was this lack of resources. So this brings me to the next point. So the resources, it was the clinical teams testified to the continuous challenges they face in terms of logistics, administration, and human resources. And this was exacerbated in Quebec because at the time of the implementation, there was a target imposed by the Quebec government in terms of attendance and accessibility to the clinic. There was a new law that was passed, the Law 20, and it was discussed in the newspaper. It was a huge law for all the practitioners. It changed the policies, and people, they had to register twice as many patients as they were used to roostering. So this means that they had a lot of stress, and they felt that research was really just too much for the moment. So our last point is some success that we, there was one research coordinator at our team, Laetitia Coudert, who had a great idea to use the Facebook, a private Facebook group. I know Facebook, there are some controversies, but I mean, it was a way for the team, because we had 4 clinics, recruitment processes in 4 clinics, about 10 employees at the time, and Facebook was used to motivate the team members. They were posting pictures. So for example, the coordinator had assigned to them a small budget to improve the rooms where the research was conducted. And in the Facebook group, they would post pictures of how they had put posters. They had candies for older adults to take when they were doing the questionnaire. So this was a very, very fun part. Also, we had another thing that was very interesting, is that we used all the research associates were wearing t-shirts, red t-shirts with the label research. And this allowed to an easy recruitment, and even 2-3 years after the end of the project, the patients still remembered us in the clinic with these red t-shirts. So I'm just sharing this as a good way to do recruitment in a clinic such as we did. So thanks very much for the time, for attention, and I'm going to pass it to Susie to explain what happened in Ontario. Thanks everyone.
Merci, Anik. So I have the pleasure of sharing our unique findings in Ontario. And in Ontario, we had 3 sites, 2 were, and all 3 were comprising team-based practices. So in meeting with the primary care sites and the community agencies that were regularly referred to, our team noted differences in options of referral. So for instance, in one of our sites, there was a robust process already in place for internal referral to services such as dietitians, mental health counselors, chronic disease management specialists, memory clinic. And so there were a variety of referral options already in existence with an internal pathway. Conversely, in one of our other sites, there were very few internal referral options and more options for referral to outside community-based resources. So the reality of this difference and variable access between internal and external referrals required thoughtful planning and discussing when looking at care planning, post-screening. In Ontario, the term shared decision-making and its associated tools, as mentioned both by Sara and Jacobi, were considered a little bit more novel than in the province of Quebec. And though our providers were comfortable with the concept of both patient engagement, and they agreed that they were absolutely committed to eliciting patient goals within their practices, the placement of the decision boxes within current practice actually required some specific planning and discussion. Not only that, but we tailored the training specifically in Ontario to focus a little bit more on the foundational background of shared decision-making. Another interesting development related to shared decision-making was that there were already some referral pathways in a few of our teams, as I mentioned earlier, to both dietitians and mental health counselors, meaning that there were some natural folks with whom we could also train around shared decision-making, such that if the decision box around malnutrition or the decision box around depression was triggered, there was a natural care pathway to the mental health counselor or to the dietitian. In terms of care coordination and service system navigation, CareGov is a very well-known and established referral mechanism within Ontario. It was known previously at our sites, even prior to inception of this project, but had actually advanced with some of its capabilities since perhaps the providers had used it in the past. So what we know now is that CareGov is integrated into many of the EMRs across Ontario, and that there are direct booking mechanisms available, which were really important to our providers. We heard that in our pre-implementation findings, and then we also heard how important that was in the care planning pathways. As Jacobi mentioned, in Ontario, many of our primary care providers are now using the Ocean platform, which allows our electronic medical record vendors to actually extend their functionality. So it enables tablets to be used in waiting rooms with the opportunity to have the data uploaded into the EMR. It enables information to be sent out to patients in advance of appointments, etc. So prior to our COVID pause, one of our clinics had actually planned to utilize the screening on tablets in the waiting room and have that information uploaded right into the patient's medical record for further directing of next steps. Next slide, please. In addition to the lessons learned that you've heard through Ontario, through Quebec, and throughout Alberta, we also wanted to synthesize and focus on a few salient, broader lessons learned. Some of these have already been touched on in previous slides. But due to the cultural nuances of language, we really learned that when translating online platforms, training materials, screening tools from one language to another. So in our instance, most often from English to French, we learned that it was imperative that the person who was doing the translating have French as their primary language. Our baseline interviews and subsequent work at each site also helped us to understand that a one-size-fits-all approach was not going to work with our intervention tools. It wasn't responsive and it wasn't supportive of the great work that was actually already happening within the primary care practices. So we needed to attend to the individualized practices, not only of just the providers, but also the unique aspects of each provincial site and focus. And as shared throughout this presentation, shared decision-making is a perfect example of how we really adopted and tailored to meet the needs of both the sites and the provinces. 2 project leads were identified at the outset of the study to ensure fidelity and project goals. However, each province had a real true local implementation team that was supported both by the PIs of the province and the 2 project leads. And the local implementation teams were actually key to the planning and tailoring of the implementation tools to each site. The project leads were very instrumental, however, in maintaining communication between the provinces, in helping with iterative learnings between the provinces from inception to closure of the project. And I think this is what really contributed to greater shared learnings and success of the project between each of the sites and the broader team in general. I wanted to highlight one particular bullet on this slide, and that's the buy-in at all levels. And we've talked a little bit about this through various slides, but it really became apparent through our discussions at each of the different implementation teams provincially that each site had a very different concept of what buy-in meant. And I'll just provide you with an example. So at one of our teams, it became pretty apparent that buy-in meant presentations in advance of implementation at not only the board level, but also the physician level, and then at the allied health level. At other sites, it was really about being able to get buy-in with one particular group practice, with one particular physician, with a group that wrapped around that physician. But I think the bigger takeaway was that buy-in, however it worked for that particular site, was going to be instrumental in looking at the sustainability of the project. Next slide, please. The next few slides, we're going to showcase for you how the project evolved to translate our actual learnings into practice. So this is an example of a tangible outcome. It's the creation of 3 implementation guides specific to each province with the learnings that you can use if you may be interested in applying our experience to your own practice. Each guide has been created with the local provincial context in mind. Next slide, please. So these guides can be utilized by primary care practices who may be looking to implement screening, care coordination, patient engagement. On this slide, we're highlighting for you how we translated our learnings into key questions and considerations for primary care practices to address how they would consider implementation. So for instance, thinking about logistics such as who's going to conduct the screening at our site, who will facilitate the decision box discussion with the older adult, who do we ultimately need to have buy-in to make this project a success? Next slide. Within the guides, there are pages in which each component of the intervention is broken down with key decisions that will affect and help you to make a decision about how the components are incorporated into daily practice. So these pages actually help providers to move through the integration process of the components. So for instance, on your screen, you can see that the first couple of boxes identify how you may use the screener within your particular setting. and then how you will translate the screening results to the next component of not only care coordination for use with something like a platform such as CareDove, but also how you will continue the patient engagement discussion using tools such as the decision boxes, etc. Next slide, please. We've provided you within the implementation guides some examples of the models that we utilized in a couple of our sites. And we've used icons to help you to understand the process as it's built into each component or each intervention component. So if we look at the first line of this slide, you can see that this site decided that 2 weeks in advance, patients would be identified to go through screening, and that the designated clinician, whomever it might be at this particular site, was going to do the screening over the phone. That was how they decided at this site to utilize the screening process. With the results, a subsequent appointment was booked with a particular provider to work through the results of the screening, which may have identified education as necessary, certain referrals that would be necessary, and how they were going to utilize the decision boxes based on that particular screening. A follow-up appointment was then scheduled 1 to 2 weeks later, in which the one-page decision box that may have been given out at that previous appointment would then be explored in more detail with a provider who had access to the full document, the full documented decision box. And at that appointment, referrals would be made utilizing CareDove or internal referrals. Ongoing monitoring would happen, and this whole process would be repeated at an annual review or when necessary as deemed by that team. Next slide. So these resources are available all for you online. You can download each of the implementation guides, which will have subtle nuances associated with the provincial learnings. Next slide. You can access the worksheets that we just talked about, the checklists, the sample models for more in-depth information. And key to this project was our real strong focus on the empowerment of our older adults and our providers with tools to assist in goal setting and engagement. So the team felt really strongly about ensuring access to not only the one-pagers, but the fulsome decision aids, full decision boxes on the website. So on this website, both providers and older adults can download the most current, up-to-date best practice information on the 5 decision boxes. Next slide. So we would be remiss if we didn't share with you where we are now across each of the provinces. In Alberta, the screening tool is still in use and actually has spread to other clinics within the primary care network who were not initially a part of the project. It has also instigated the exploration of other frailty screening tools in primary care. In Quebec, the tools are being directly tested in the community now. The decision boxes continue to be used at the sites that completed the full intervention, and shared decision-making training is now offered as a continuous professional development in both English and French. In Ontario, we have many sites that are still, of our 3 sites, actually all 3 are still using the screening tool and CareDove, and are actually very interested in continuing to learn more about shared decision making. We've also been able to share our learnings at Ontario Health Team tables, who have a true focus on implementation in primary care, particularly around the frailty realm. Next slide, please. Such an extensive project would not have been possible without the significant contribution of a myriad of organizations. You know, what's that saying? It takes a village. Well, we wish to acknowledge and give credit not only to all of these organizations that you see listed here, but to the very primary care sites and providers in each of our provinces. We truly worked with some phenomenal people who care passionately about innovation and innovations that seek to transform care for our older adult population. Thank you so much.
Okay, thank you very much. What a fabulous presentation and a huge body of work. I think we have some time for a couple questions, and we do have a couple open in the chat box or in the Q&A. So anyone who has a question, I encourage you to enter it in the Q&A, and then hopefully we can get to it. There was one question we had about the project exploring patient and partners in care perspectives, interpretation, and expectations of shared decision-making. Anik, do you want to speak to this?
Yes, thank you. Simply to say that we did indeed explore all stakeholders' perspectives about each component of the intervention of the care pathway. So this was a systematic process in each province. In each province, it was really to check how people thought they could embed the tools, including the shared decision-making tools. We did not really look at the expectations, though. It was more like, you know, we did not ask them their opinion about shared decision-making. We proposed to them these tools as a start. So I hope this answers the question.
Great, thank you. There's another question that came in that was asking about the ocean tools in particular, and whether or not the team thinks that it could be used for patients and families in waiting for primary care service provider. So for instance, at a walk-in clinic, or using to triage patients on a wait list for a primary care provider. Would somebody like to answer that?
I don't know, Susie, if you're best to answer that. So just looking at the question, can you repeat the question, Amanda?
Sure. Does the team feel that the ocean tool could be used for patients and families who are waiting for a primary care service provider? So for instance, at walk-in clinics, or for triaging patients on the wait list for a primary care provider?
Jacobi, do you want me to jump in?
Yeah.
Okay, so the tool that we used as part of our project was one of the InterRye-based tools. It's the preliminary screener, or the assessment urgency algorithm. And, you know, I think one of the key pieces to keep in mind with using any screening tools is the intended outcome. And so there does need to be somebody that will follow up post-screening with the results. I haven't heard per se of this particular tool being used in the capacity that you're asking. And so I do wonder if it might be best to reach out to the InterRye group through the University of Waterloo to see whether there may be some opportunities to consider the use of that tool. It's just the piece around the next steps and who will follow up if something is triggered within that tool, because it really is addressing risk, and risk around conditions such as mood, increasing complexity related to chronic conditions, cognition. And so with any screening, it would be important that there's a mechanism in place for somebody to follow up. So I'm not sure that that answers your question per se, but that was just some of the thoughts that I was thinking about as I read that question.
Thanks, Susie. And maybe I'll jump in there in part to tie in the question that I see online from Larry Chambers, which was, what are the characteristics of primary care practices that will try out the tool? So to clarify on that question, our study, as described here, involved team-based primary care practices. So they were family health teams, community health centers, primary care networks in Alberta, and so forth. So they're all team-based practice settings. I realized that that is a bit of a limitation. As a bit of a sub-project or sub-part of this project, we did some exploration of what might be possible in non-team-based settings, possibly with solo practitioners or in other contexts. And one of the examples that came up was the use of pharmacists who might play a role in screening. And we had some pharmacists in our group that we discussed that with, and it seemed like it would be a feasible thing for them to do. But again, it gets to the point that Susie raised. Once, if you screen someone, you need to have someone to refer them to, and those mechanisms aren't yet in place. Also, pharmacists in the past year, as a couple of years, as we know, have gotten very busy with other priorities. So may not be the best time to further explore that. But that was something we thought about in some related parts of this work.
Thank you. And then we have time for one more question here. And so any further follow-ups planned on looking at how the implementation of these tools impacts outcomes for older adults?
Was there further follow-up planned? Yes. Were we able to do it as much as we wanted to? No. So we did some follow-up. We were hoping to have another cohort where we would do outcome assessments at each of the sites. That was completed in one of the sites in Quebec. But when the pandemic hit, that put a stop to things, and patients were unwilling to be having anything else added to their list of things to think about, and primary care practitioners were very much preoccupied with other things. And at this point, we're at the end of our resources for this project, but we have, developed some good relationships with the study sites. We know that use of many of these tools is going to be continuing. So there is the potential, perhaps down the road, to look at what the ongoing impact of those tools have been.
Terrific. Thank you. Well, I think that that's a good way to end it. So I'd like to thank again our speakers today for all your hard work and telling us all about it, and importantly, those implementation resources that are available on our website for anyone. And of course, I'm sure they can reach out to you to find out any more information if they're looking for it. So if we didn't get to a question or you think of it later, I'm sure they'll be happy to answer it. So thank you again, and keep an eye on the CFN website for future webinars. Thank you.
Thank you.
Thank you.